Okay, folks, good afternoon. Thanks to all for coming. So this is an hour-long staff briefing on improvement in patient flow, or how we're trying to improve patient flow across the UL Hospitals Group and across the community. And it is very much an integrated approach. We're lucky ourselves in UL Hospitals and CHO3 occupy the same geographical footprint. Other groups and CHOs haven't that luxury, and it does make working together much easier, because for the vast majority of patients that we're dealing with, they're coming from within that catchment area, so we're not going outside our catchment area trying to, develop relationships with multiple CHOs like some of the groups have to do. So together we've embarked on an improvement program to deliver better patient flow. And why are we doing this? There's an increased demand in unscheduled care, and we can see that every day in our ED. We've increased attendances at our LIUs. Our MAUs are, almost at capacity. There might be the odd space the odd day, but really are functioning at full capacity. And also then the Sláinte Care Reform Program, which is moving care from the hospital to the community as much as possible, appropriate care back to the community. So we have a number of initiatives which we'd like to brief you on today, and we have a number of speakers. So that's my bit done, thanks be to God. So I'm going to ask William to come to the podium, and he's going to talk to you about our daily operational safety huddle.
Thanks, Tina. Good afternoon, everybody, and thank you for coming. I know that trying to break out of your day isn't easy, so we do appreciate you coming to hear this. So the daily operational safety huddle is not a new phenomenon. It's used around the world in relation to safety huddles to provide a safer, as it says, a safer front to our hospitals, to how we present our care and the outcome and experience for our patients. In initiating this back in August, September, October, the point of this is to reduce the number of huddles that we already have in the hospital. So I know there's a nursing huddle at 7:30, there was a huddle at 9, a huddle at 10, a huddle at 4, and this was hugely laborious and time consuming on most people's behalf. So what we've done now is we've reduced the huddling down to 2 at 9 a.m. and at 2 p.m. The reason we brought them back to those hours is that it gave the opportunity for the patient flow team to affect and change in relation to patient movement, and obviously executing what needed to be done for the patients earlier in the day. So the 9 a.m. huddle is attended by quite a number of people. The executive team have representation every single morning. So you could have the COO, the CDOM, you could have anybody from the executive team, and we're privileged in having somebody and that level of commitment from our executive team to ensure that they're there on a daily basis to support us. We have the head of operational services, that is myself for the moment. We have the directorates, and we have the CD. Less present than everybody else, but they are, when they are able, they do join us. The DONs, ADONs, USC lead, who's often this co-chair, Aisling Ryan and Noreen Spillane, our COO, are the co-chairs for the USC committee and council. We have all our community representatives, and this was key to us and the success of this, because our reach is not just about our hospital, our reach is into the community and how we get feedback and inclusion from them in how we move our patients, the bed availability, and the basic communication process between us and them, which was sometimes a little bit fractured or frail, but now we seem to be building more on that day by day and week by week. We also have our diagnostics team, who we know it has been a challenge in the past to try and access this. Now we see that there is more of a collaborative upfront accountability perspective from diagnostics, because we can ask questions of people and hold people accountable for what actions they have. And of course our infection control team, who I see here in the audience, and thank you for coming as well. The basic key principle of it is that we get a site report every morning at 9 a.m. And in actual fact, some of the figures are there beforehand. This allows our patient flow team and our discharge coordinators, thank you Aisling for joining, our discharge coordination team to action the flow of patients from the wards, either for transfers to our Model 2 hospitals or to discharge to nursing homes or to home. We have the day's demands. So we all know that the emergency department is in crisis point most days, and this gives us visibility of their staffing and their pressure. But what it also allows us to do is it allows us to reach and give that information to our Model 2 colleagues and the community. There's nothing like a little bit of perspective of the pressure that people here in this room and throughout this site are under for people to understand. And on occasion we would equate what's in the emergency department to an entire institution, such as there were more patients in the emergency department than there was in the entire populace of Ennis and Nina one day last week. And that's a very stark figure to give people, and that verbiage around it brings home to people that are on, I suppose, less occupied sites or less fractious sites, for them to see exactly the pressure that the people here, both on the wards, in the emergency department and the support services, are under. We also look at our critical care capacity every single morning, which is vital. Obviously, our most critical patients are within our ICU, HDU and PHDU areas, for which our PHDU unit today is at more than 100% occupancy. And that allows us to plan for what we need to do in terms of bed capacity, discharges and coordination for that. Patient flow, as this is all about, is key. Again, giving us the visibility from the different patient flow perspectives on where we have pressure points and where we have relief to be able to plan. So if we hear that there are potential discharges of 7 or 8 in different sites, that the flow team can then pinpoint their efforts there to ensure that patients move in a timely manner from those areas. Our Model 2 colleagues, they are very, very present on these calls, and they are very upfront. They have become definitely closer to what we need in terms of support mechanisms. They are very transparent in their availability each morning at this time. They will immediately identify where they have capacity for admissions for male, female, IP and C, and this is very fruitful to us where we can and see transfers happening early. Again, as I said earlier, our community capacity, such as St. Itas, St. Camillus, Hospital of the Assumption, our rehab and our long stay beds, we have visibility on that every single day. I suppose the execution of transferring people then comes down to ourselves and our clinical colleagues who support us in providing that, but that sometimes is a bigger challenge. We also a key focus, obviously, of the huddle is the safety aspect. So if there's a safety incident that happens in one location, that we actually bring some verbiage to that and we bring some highlight to it, so that the same issue may not incur to a patient in another location. And sometimes that can be very real and very, I suppose, changing in how we look at things, because all of a sudden somebody says, oh God, that could happen here as well. And, you know, what did they do in that location to prevent that happening? And I think that's the key part of the safety huddle as well. If there are issues or concerns that anybody has, that they raise them at those huddles, and there is opportunity at the end of the huddle for anybody to bring items that are outside the list here for them to showcase those, and obviously we support that. So we would ask people if they wish to attend that. We will be in the new year expanding the capture of that, so we would like CNM2s to join that, CNM1s and Allied Health Professional Services, so that they hear what goes on. That visibility sets the tone for the day and sometimes for the week, and that's key. So thank you very much for that. Sheena, thank you.
Thanks, William. So next we'll have some of our community colleagues up. Ina Hooley, Complex Discharge Coordinator. Sheila's a physio with the MDCIT team. And Anne-Marie Brown coming from OPAT in the IT, so they'll do the next presentation.
I'm so sorry, Sheila English couldn't make it this afternoon, nor could Anne-Marie Brown. So my name is Emer Cagney. I'm an occupational therapist with MDCIT here in Limerick, and this is Ina Hooley. Am I turning it off? Oops. Sorry, I pressed that one. Oh, okay.
So my name is Ina Hooley. I'm Assistant Director of Public Health Nursing, and I am one of the members of the Complex Discharge Liaison team. A member of our team is the primary care discharge liaison occupational therapist, Paul Fitzgerald. Paul is on leave this week, so I'm just going to give a brief outline of his role, and if you have any questions relating to Paul's role, I'm happy to feed them back to him. So Paul's role is to support the community discharge liaison team in facilitating a safe and timely discharge to patients who are going home. The inclusion criteria for his role is patients with complex clinical presentation requiring an OT assessment to identify essential assistive aids and appliances required to facilitate a safe discharge home. The exclusion criteria for Paul's role is are for patients who are going to rehab, patients who are going to long-term care, and patients who are already in receipt of a UHL OT service. And then these are just an outline of the wards that Paul covers. So the complex discharge liaison team itself then comprises of myself, Assistant Director of Public Health Nursing. We have a public health nurse on the team, discharge OT, and a clerical officer. And the plan next year going forward is to expand that service to an additional public health nurse, community RGN, an additional occupational therapist, and 2 clerical officers. And the aim of our service is to facilitate a safe discharge of adult patients with complex needs, to minimise the service users' length of stay, to reduce the readmission rates, and support UHL hospital group with bed management and capacity. The inclusion criteria for our service are adult patients whose destination is to discharge is home, who have experienced a physical or functional decline since acute hospital admission. Their home has become environmentally unsafe and have high physical dependency care needs. The exclusion criteria are adults under the age of 16, adults under the 16, acutely ill or unstable patients whose needs cannot be met in the community by community care services, and acute mental health issues. The referral process is the completed CDLT referral form, emailed to CHO3 discharges. Following the receipt of the form, we aim to see patients and assess them within 24 hours, and depending on capacity, urgency and complexity of the case, and bearing in mind that our service is Monday to Friday 9 to 5. Once the referral is accepted, we will then carry out an assessment to determine what supports or equipment will be needed to facilitate the service user's safe discharge to home. And the next slide then just outlines the level of referrals that are come into the discharge hub on a daily basis over the last number of weeks. It's averaged about 100 referrals a day into the CHO discharge addresses. I have yours here, yes.
Sorry, I don't know if my slides were passed on, but so the multidisciplinary community intervention team, or MDCIT, we are a multidisciplinary home-based rehab service following early support discharge from acute settings and minimising requirement for inpatient rehab, step down or transitional funding. In each area, so between Limerick, North Tip and Clare, each team has 2 WTE of physio, 1 WTE of OT, and we have 2 therapy assistants in Limerick, one covering West Limerick and South Limerick, and the other covering the city and East Limerick. In Clare and North Tip, they have been sanctioned the same amount of service or staffing, but they don't have all of them in post at the moment. We have a 24 to 48 hour response time. We work Monday to Friday, and we provide a minimum of 2 weeks home-based rehabilitation. It's a therapist-to-therapist referral, so they must have been assessed on the ward by a therapist, and that therapist then would contact us to refer the patient. It's a separate referral form to the PCCC or the CIT nursing/HCA service. We don't hold a waiting list, so therefore sometimes we don't always have capacity, and the patient is accepted based on their suitability for the service and or capacity. The patient must require input from 2 disciplines, and they need to have realistic goals and, I suppose, show some motivation for rehab and carry over on the ward that they have the potential to improve within the short intervention period. I do apologise, I don't know where I sent my slide off, but I don't know where it went after that. So I suppose initially when MDCIT started off, our service was primarily for the fractured neck of femur patient in the Croom Hospital, or coming from trauma, and there has been some really good stats to show that it can really shorten the length of stay for that patient. So we'll say in 2019, the average length of stay for fractured neck of femur would have been about 17 days. It came down to 14 in 2020 and 11 in 2021. And I suppose it would be interesting to see what it'd be for 2022. And it also showed that we've had a reduction in the spend for transitional funding for traumatic hip fractures in those 3 years. So there's been approximately €882,000 saved on transitional funding in 2021. And then I don't know, you don't have slides?
Yeah, I have. The manager for the community intervention team is actually on sick leave today. He's just asked me just to briefly just outline the role of CIT. So it's a 3 areas support. It's early supported discharge, hospital avoidance, and admission avoidance. So under the early supported discharge comes the category of OPAT, which is 6 weeks IV medication administered at home or in the CIT clinic. There's home parental nutrition, medication infusions, MDCIT, as Emer outlined, and home support healthcare assistance. Under the hospital avoidance, there's community oncology, which is available 7 days a week, urology support, which is available 7 days a week, 8 to 8, which includes catheter education, catheter replacement scheduled and emergency. And under admission avoidance, Optiment referrals to the MDCIT, the AMU, the SAU and the LIU can also refer to CIT for their support as well in the community. Any questions?
Is there a catchment area for referral for these, or
for CIT or for
CIT?
Yeah, there's 3 separate offices in Limerick, Clare and Tipperary.
So I'm talking more like West Limerick.
Yeah, we covered the whole. So the nursing staff have a team in West Limerick, who cover West and South Limerick, because they like the Kilmallock area as well. And then the therapies, we cover the whole county. Yeah, we're based here across the road, but we cover the whole county. Yeah.
Okay.
Thank you.
Thank you.
Okay, thanks, ladies. Those figures really, with the reduction in the length of stay in the trauma ward, are really impressive. If we could replicate it across the hospital, it would make my job easier, everyone's job easier. So Shirley Rail is next, and Shirley is the group lead for Allied Health across the group, and she's going to talk to you about the gym unit.
Afternoon all. So William just said earlier, you know, our EDs are constantly in crisis, and so we're looking at different ways of trying to best manage the patients that come in. And the GEM unit, which is the Geriatric Emergency Medicine unit, is really focusing on those over 75s. So what I really want to, why are we focusing on over 75s? What have we done for this cohort of patients, and where are we going to go? So why are we focusing on the over 75s? These are a population that when they come into hospital, come into ED, they're adversely affected by their admission. They have adverse outcomes due to prolonged ED exposure. And we know internationally that about a third of those over 75s admitted to hospital experience a functional decline, which then makes it harder to go home, increases length of stay. Also, I think it was the Department of Health last week came out with they stated that Ireland has the fastest growing population of over 80s in Europe. So this is an age population we really need to function or to focus on. Also, post-COVID, we're noticing an increased complexity with patients coming in, and also there is an increase in manifestations due to delayed post-care or delayed care post-COVID. So we really need to look at what we're doing for this age population. So what have we done previously? About 4 years ago, we had the Optiment Program, which was a pilot program that started off with AHPs or HSCPs in ED. Historically, there had been no HSCPs in the ED, so we started with a pilot of 1 physio, 1 OT and 1 medical social worker. So I think what's really interesting to see and to look at is the number of patients assessed this year alone, 895, and their discharge rate home from ED. So it's patients who come into ED and are discharged straight through an intervention by the HSCPs is 70%, which is a huge percentage of those over 75s discharged home. what other data that we collect is also that we don't want to just discharge them home and then they arrive back 2 days later or 3 days later because they have the same issues. Our incidence rate of 30 days unscheduled revisits is only really about 12%. So they've actually really good discharge pathways and egress pathways out. So I think it's really important to look at that. So this was a program we were running. We do know our over 75s, there's issues and we really need to try and maintain them at home in a safe place, because ED isn't a safe place for the over 75s. So along with community, I suppose what we've been looking at with the ED or the Optiment Program is new pathways of care and new ways of working. So it's really great with enhanced community care and with Sean's care over the last number of years that we have many new egress pathways out of ED, which is we can refer to MDCIT, as the girls previously had just been talking about. There's ICPOP hubs, ambulatory care. So we're looking at all of these ways, and these are all new ways of working. Frailty at the front door has also commenced here as well. And the team with the frailty at the front door at the moment, there's a CNS, a 0.5 of medical reg, and I think admin staff with that. So they're all trying to work together. So this is what we have been doing. These are the new ways of working. But what is our vision? What is our vision for the geriatric emergency medicine unit? What we really want is that we have a streamlined pathway for patients who, when they come to ED, can be triaged from point of ED when they're identified straight to the GEM unit. Again, what we're going to have in the GEM unit is that they will have a comprehensive assessment and intervention and really focusing on discharging these patients home. So normally it is the patients who we'd be looking at being transferred from triage to the GEM unit is those who have a lower acuity, maybe more function and mobility issues, rather than being acutely unwell. Obviously, if they're acutely unwell, they're going to have to be maybe be admitted through ED, be attended by consultants, and may end up being admitted. So what we're really looking at is those lower acuity patients that we can turn around and safely discharge them home again. What we've done to date, so we know the Optiment Program was extremely successfully evaluated. So it is something we want to replicate and enhance. So what we're now trying to do with the GEM unit is trying to increase the staffing that's there. So we've got approval for additional staffing, and we're currently in the middle of that recruitment process. We're extending the hours. We very much recognise that things don't close at 4 or 5 o'clock in the day, especially in the hospital. It's 24/7, and traditionally AHP teams are kind of 8 to 4 or 9 to 5. So we're looking at really trying to maximise what we can do for the patient. So at the moment, because we haven't onboarded our new staff, we're working on we've increased hours to 6 o'clock, and the aim is in the new year to be 8 to 8 service for the patients. Again, really what we're looking at is getting really comprehensive multidisciplinary assessment for the patients to discharge them home safely using all of the egress pathways that have really come on board with the enhanced community care. I can take more questions at the end if anyone has any questions on that. Okay.
Thanks, Shirley. So next we have Geriatric, who's going to talk to us about ICPOP.
Hi everyone, my name is Geriatric. I'm one of the operational team leads in Integrated Care Program for Older Persons, and I'm based out in the Ambulatory Care Hub in Thurles. There's two of my colleagues then that work. We have another Ambulatory Care Hub here in St Camillus' Hospital in Limerick, and we have one in St Joseph's in Ennis. So there's 3 hubs across the CHO, and we're all operational. I suppose realistically we started putting staff in place around this time last year. And Claire, you went live around February, March. We were live, say, from January 2020. So we're kind of, I keep saying we're in our infancy really, but we're getting there. So I suppose the most important thing is really for you to understand where we actually sit within the integrated care, the whole integrated care model. So this is based on the National Older Persons service model, and everybody is very familiar with that and know our story. So the whole thing is, myself and Anne-Marie were discussing it earlier, the whole thing is that we're always looking left, trying to keep the patient at home, and that's our focus. So we have our primary care colleagues then in the other circle, and as you can see then the ambulatory care hubs are sitting kind of between acute services, and the community. So our whole focus really is the model is for continuing care in the community with the aim of supporting admission avoidance and, if possible, to support early discharge to home. So that's really where we're about. And I suppose the whole thing, when you see there multidisciplinary teams, and what does that mean? Well, for us it means that we're headed up by consultant geriatricians in the hubs. So they carry our clinical governance, and then we have nursing. At the moment we have candidate ANPs. I have registered ANP as Sheila Ryan Stoller from here, and we have physio assist, ideally OT and OT assist, but some of us are in various stages of development with that. All those posts aren't filled yet, and we have some MTAs in the hubs as well. SLTs are shared across the services, and Clare Hub have a dietitian. So that's really what we have at the minute. So what does it mean really? Well, it's a service that provides rapid access really to consultant geriatrician. Basically that's what it is. And for the patients that have frailty and are developing frailty or have had falls or at high risk of falls. So our aim is to offer appointments within 1 week of the referral being received from the referring agents. But what we do is, if we have any referrals from the acute services, we aim to see them within 24 to 48 hours, if it's realistic. And the following outlines then we do a comprehensive geriatric assessment, I think kind of similar to what they're doing here in GEMS as well. And we have a rapid access to a falls assessment, but including the provision of special diagnostics on sites. So what does that mean? Well, I suppose we have the diagnostics that otherwise would have been heretofore delivered in an acute service. So we have APPMs, Holter monitoring, ECG, tilt. We have a DEXA and Thurles, which is operational since September, and so we have that going on. And then because we have the geriatricians as well, we do quite a bit of medication reconciliation, which is a big problem actually for a lot of patients that are referred into us from primary care. Like medications not being reviewed and all that kind of thing. So that's really a good bit part of it. So basically, it's an outpatient rehabilitation rehabilitation service delivered to patients on a weekly basis, and they attend for up to a maximum of 6 weeks, and then we have coordinated onward referrals back to our community, our primary care colleagues, or to other external agencies. We do a lot of links in with other external agencies as well. But the main thing is that, like, the on-site diagnostics that we can do hadn't been provided before the hubs were in place, which is really, really good. So the referral criteria, now this is a work in progress. This is what went in at the very, very beginning when we set up. So the referral criteria was that patients would be over 75, age 75 or older, that they had evidence of frailty scoring between 4 and 6 on the Rockwood clinical frailty scale. So basically they were pre-frail, mildly or moderately frail, because there was no point sending, like the whole thing about an ambulatory care, patients can walk in the door. So if they're very complex, we wouldn't really be able to offer them, a good service with good outcomes. We do ask that they do reside within the catchment area, and that they've been seen in person by the referrer, because they're being referred in by the GPs. They do have to be seen, because there's no point a family member ringing up and saying, I think they need to go to ICPOP, when maybe they're not suitable at all. And that they haven't had MDT input within the last 3 months. There is flexibility on that, because some patients have been referred maybe have been seen by an OT in the community, for instance, but maybe haven't gotten physio, or they've had a fall and they have been seen by the OT in the previous 3 months, but obviously we're going to take those patients. And then any one of the other referral criteria 6 to 9, so that they've had they may or may not have had a fall within the last month that might require further evaluation, but they have an increased dependency or an increased care burden in the last month. So that expression of they're gone downhill, or they're not quite as robust as they have been. A lot of the patients that we see have been, they were victims of COVID, really, because they were isolated, and they were, they just didn't have the same, I suppose, social inputs that they had prior to COVID. That they might have had a deterioration in swallow in the last month, including symptoms of recurrent chest infections, weight loss, coughing, and that's where the SLTs come in. And that they've had an adverse drug reaction within the last month, but but not related to an anaphylactic thing or something like that. But sometimes people are put on medications and they might be reacting to them, they might have had a fall, and we just, we kind of reassess all that. So like I said, medication reconciliation is quite a lot of what we do. The number of referrals, it's 8, I think I can't really read that slide actually from here.
2-1.
Yeah, 821. Yeah, 821. But that was up to the end of October, I think. And Maria, am I right in saying we're up to 900? 921 is our figure now, and out of that, 671 have attended. But the thing is that 71.2% of our referrals have come from GPs. Because we're on HealthLink now, which has really pushed up the referrals, and from the acute floor and MAUs and frailty at the front door and Optiment, we've had about 21% of the referrals, another 7.5. So I suppose the frailty, the acute service, of course, the acute hospital is referring to us, but I suppose the whole thing about the GPs referring to us is that we're heading people off at the pass, that they're not presenting in here. But like, how are we going to measure that? Well, at the moment we have we've research going on with UL at the moment. They're right across the 3 teams. UL are doing a piece of research on the outcomes for patients and who is and isn't presenting to us. So hopefully we'll have the results of that research, I'd say mid to late 2023, by the time we do all the follow-ups. So there are the numbers across all the 3 sites at the moment, and obviously Limerick has the biggest catchment area, so Limerick's referral rate would be higher than ours, say, in North Tipperary. But that's the way it's working out at the moment. So how does it work? Well, basically, when we get in a referral, all the referrals are triaged within, once they come in, they're more or less triaged straight away. And when they come for their first appointment, and like I said already, we try to see them within 7 days, if that's realistic. It depends obviously on leave and all sorts of things, no more than any other service. So we do a detailed review, which can take anything up to 2 hours. And the thing about our teams is that it's interdisciplinary, so it's not just one member of the team or the nursing team just doing the CGAs. It can be any member of the team, which is really good. And then every week we have MDTs every week, where all patients that are active are discussed to make sure that their treatment plans and the reviews are being carried out, and that they're reviewed by the relevant ICPOP discipline for up to 6 weeks. So basically, if somebody's coming that have had falls work up and then they're deemed suitable for the physio, and then they go on to the physio for a period of up to 6 weeks. They may or may not be seen every week, it depends. In Thurles, we had one of our physios has a particular interest in vestibular studies, so we were doing a lot in that line. We actually have a piece of research going on with consultant Elaine Shanahan and our physio at the moment, which is proving very, very beneficial. And the other side of it then is that they are referred on to appropriate external agencies, if that's post MDT, if that's appropriate. And once the 6 weeks is up, and it's not always, strictly within 6 weeks. Some patients are discharged before it, and some might have to go on for another couple of weeks. They're discharged back to their primary care colleagues or back out to whichever discipline is suitable for them. So that's it. We have three generic email addresses for each of the teams in Clare, Limerick and North Tip, and we're also up on HealthLink, which has been proved very beneficial from the point of view of our primary care colleagues. So that's it. Is that okay?
Thanks, Joe.
All right.
Jared, can I ask you?
Yeah.
Sorry. You were saying as well that any patient that's referred on actually has to be seen by a reviewer first.
By the referrer.
By the referrers,
Yeah.
has to be reviewed. If they have to be seen by a referrer.
Well, whoever's referring them has to have seen them.
In person.
In person.
Perfect.
Yeah.
Yeah, that's fine.
Yeah. Once they've seen them, that's fine. Yeah.
Okay, we will have a question and answer session at the end, and anyone that's watching us online can submit their questions online, and we'll answer them at the end. So last but not least is Aisling Brown. Aisling is assistant bed manager here in UHL. She's going to talk to you about the long stay review, which takes place each Tuesday.
Hi, good evening everyone. So I'm the assistant bed manager in UHL, there's 3 of us.
and I'm also the discharge lead. So I'm going to talk about the Longstay Tuesday, so basically an overview and the aim. So what is the overview of the Longstay Tuesday? So it focuses on any patient who has been an inpatient for 10 days or greater. A Longstay Tuesday event brings together a UHL group, CHO Midwest, working together to support improved patient flow across the system. Recognises any blockages and red days, and it challenges and improves and simplifies complex discharge processes. So what is the aim of the Longstay Tuesday? So it's to free up beds and increase flow as part of the escalation process, to reduce each patient's experience time in PET in the emergency department, to reduce the length of stay for our patients, increase morning discharges earlier, and to improve patient experience. So the process, who is involved and how does it work? So involved is bed management and patient flow, discharge support team. We don't have a full team at the moment, but hopefully in the next few weeks we will have a full team for that. Unscheduled care, nursing management, allied health and community services. Longstay Tuesday, so the key questions when we go to the wards every Tuesday morning, what do we ask? So the process for each patient's care, what are the next steps? Is there a clear discharge plan? What are the next critical steps happening today, and what can be done to enable that to happen? So what can we do to prevent any blockages in the hospital? Why do we review patients with a 10-day length of stay or longer? So the reason we review the length of stay greater, it increases the chances of 30-day admission, and we have stats to prove that. To understand the next steps required to reach discharge, it ensures critical interventions happen without delay. Patient lists and templates facilitate collection of real-time, just in terms of IPIMs, so that they're actioned and escalated. So we meet then, a debrief session happens with the full team members. We outline clear actions and assign them and make sure they are completed. Any processes, systemic issues are escalated in the DOSH, just if we need any help in terms of community, home care packages, etc., that we can escalate that and they can assist us. Every week we are seeing significant improvements in terms of the Longstay Tuesday, and just behind every patient, behind every delayed transfer of care from hospital, there is a person in the wrong place at the wrong time. So basically we just mean that we don't want any blockages in the patient. Prior to this, we were finding that we were having a lot of patients that were medically discharged, and there was a delay that we did not know that they were there. So that's kind of what this has prevented. Longstay Tuesday has positively influenced the introduction of MDT meetings at ward level. It enhances and reboosts discharge planning and collaboration with our community colleagues. Patients are highlighted who are experiencing a delay in transfer. It improves the interpersonal relationships and promotes critical thinking and problem solving of MDT approach. And this is on the wards as well. Every day we have the wards contacting us just for help and assistance if patients are refusing to leave, for example. Highlights the importance of patients have a predicted discharge date, so that we know there's a clear discharge plan to progress that patient. And most importantly, it improves our patient's journey, reduces the medium length of stay, and promotes a safe discharge. I don't know if you can kind of see the graph there, but since we started off in August, the average length of stay and the medium length of stay has increased, and it's just improving every week, so it is hugely beneficial. And that's it.
And just to say, the national support team were down yesterday just to review how we've been doing since they were here in July, and we did discuss that data that Aisling put up there in front of you, and we're kind of disappointed really that our over 14-day hasn't trended down, or our indeed over 10-day hasn't trended down. But what they said was, when they compare our data to other hospitals, we're holding our average length of stay for those long stay patients, where at somewhere between 8 and 9 days less than other hospitals. So that is the benefit of the review. We are, we're keeping our length of stay, even though we thought we'd like to get obviously the numbers down. But actually the fact that we're holding, despite the increased demand in ED, despite the increased over 75s and all those pressures, that actually we're maintaining our length of stay when other hospitals are actually increasing theirs. So that's a good news story. So that is one of the benefits, and when all our community colleagues and indeed our own colleagues are saying, why are we doing this every Tuesday? So that is a real tangible benefit, and any reduction in length of stay or even avoiding an increase, that's one less patient in ED or several patients less in ED. So we'll open the floor to questions. Any online, Katrina? No? Or any in the audience? Not that I have all the answers, far from it.
Ger, can I just ask about the ICPOP? Can referrals come from the hospital? It's not just from community?
No.
Yeah.
No. Yeah.
And what kind of patients would you see then? So if somebody who might be suitable for MDCIT or...
Had some
Yeah.
crossover, I suppose, with
From
MDCIT.
MDCIT, yeah.
You might find some people have been discharged to both services.
Yeah.
So we would often link in with our MDCIT colleagues, because maybe if someone was discharged over the weekend, you might already be in the house as such. So then we would see them then after that.
So they'd be available additional kind of SLT and other services that wouldn't be available?
Yeah.
Okay.
We bring them into the hub then once we finished year interaction, and often our physio from ICPOP and MDCIT would collaborate to see when it's most appropriate for the other to take over.
Okay.
So they've often linked in with each other to clarify the discharges.
Does your physio do home visits, or is it mainly clinic?
They don't. Well, your physio does.
Yeah.
Their physio doesn't at the minute, but we have physio assistants coming on stream on each of the teams, and the idea is that the people who may find it a little bit more difficult to come into the hubs, that those physio assistants might in time go to the houses and do home exercise programs with them, so that we should see more benefit that way.
It's a kind of an urban versus rural thing as well, because we find in the rural areas, in Chipper area anyway, our physio assistant will go out to make sure they can do their exercises and just to oversee the environment, and then maybe not have to bring them into the hub so often. You know, they can be supported at home. But I'd say, to be honest, that'll all become enhanced as the hubs develop. You know, like the whole idea, I think originally was that there would be outreach, but we just don't have the staff for that at the minute. You know.
It is something we look at for the future. We're looking at business cases for outreach to the more rural areas where, say, particularly the over 90 bracket, a lot of the patients we would see are 85 to 95, and it's not always feasible for them to travel a distance into a hub in Ennis or out to Furless or whichever. So the planning time would be to have an outreach service to the more rural areas. So.
Sorry, just one last question. If a patient is open to MDCIT for rehab and the MDCIT therapists feel that they could really benefit from that rapid geriatrician or SLT review, or even the vestibular piece with the tilt table, can we refer into you, or does it have to come from the GP?
Well, ideally it comes from the GP, but if they've already been referred into you from I don't know, like, what we do is we usually take all those referrals, we take them on an individual basis, like, you know, that's kind of what we do. So I think the best thing to do in those situations is for the therapy to phone. Yeah, exactly. Yeah.
So what maybe might link with you know, the different services, the 3 different areas, and see, get an idea of how the service works, so then maybe it might be something that we'll say sometimes when we're doing discharge planning, we make recommendations of what might be options for the patient. So
that's it. Like Anne-Marie Brown came to see us out in Thurles now. You know, there last month. She came in October. Actually.
She I know from the wards, you know, a lot of the service might not be aware of it. Yeah. So even just so if I could document the medical notes.
Because most of our referrals, in all fairness, like have been from the MAUs or they have really. That's kind of where it kind of sat better, because I mean the acutely ill patient probably won't. It's not, you know, it's not realistic for them to come to us for a whole pile of diagnostics, and they probably already have had them done inside in the acutes, you know.
And not necessarily diagnostics, but just more kind of an outpatient rehab follow-up. Yeah.
Anyone else?
Tina, just an observation. So you can see the communication even between two groups that are very close together, that service the site and all these other areas. There's new things to share and for people to find out and know about that services for the patient that possibly we don't showcase enough to each other, not even just to the patient, but this service here can support that service, can support the patient in a different way. I think there's an opportunity for us to expand this within our own services so that everybody hears what everybody else has the opportunity of doing, because we don't know possibly the breadth of services that are out there.
No.
And I think that would be
No,
really
you're right,
beneficial.
and I think that's been one of the things, I suppose, even though, like, we, for the Longstay Tuesdays, like, because we were all rostered in on it, like,
Yeah.
we go in periodically, you know, into it, probably not as often as you do, Ina, but we were just saying actually this morning at a meeting that the one thing, like, we're, you know, when we see what's happening inside in the acute services, it's very good to keep that in mind all the time, like that, you know, that behind all this there's a hospital that's heaving at the seams, and yet, and you know, that we will try and do whatever we can to support it. But like I myself and Anne-Marie and Antoinette, the other lead, like, we would keep saying, we're, you know, we have the same problems as everybody else, like we've problems with recruitment and with medical manpower and all that. So we're you know, we're getting there, but it's going to take a while for us to bed down. Like, I was in CIT when it started off. It took us years to get it bedded in, you know, and then when it did, it became vital to the cog of, you know, community services, you know, so.
Yep. Anyone else? Okay. Thanks everyone for attending. It was recorded and it will be available for staff who weren't able to come today. Okay, thanks everybody. Thanks.